Thank you, Alan, and thank you very much for the invitation to speak to you today. I've worked in this field of shared decision-making for some time, both from an academic perspective and also from an implementation perspective. And you'll hear some of the implementation learning from Rob later on when we've been working on trying to get shared decision-making into practice. But what I want to concentrate on for the next few minutes is this question about, well, what do we mean by a well-informed patient? And in terms of the content, first of all, I want to say a little bit about what do we mean by shared decision-making, partly by giving examples, thinking about what the impact of shared decision-making is, and some of the evidence that underpins the importance of that, much of which you've already heard in that very brief but very rich presentation from Alan. And then talk about in a bit more detail, well, what's actually needed to do this? What's needed to support patients into being sufficiently well-informed to engage in the sorts of decisions that Alan was talking about, and then hopefully pull that together at the end. So let's start off with what is shared decision-making. As Alan's already said, this is about decisions where there's more than one reasonable option. And the more I look at clinical practice, the more I recognise that there are very few decisions that don't have more than one reasonable option, even if that reasonable option is to do nothing rather than have the treatment. We tend to think, so my definition, and the definition I prefer around shared decision-making, is it's an approach where clinicians and patients make decisions together using the best available evidence. So it's not about ignoring the evidence base. In fact, it's about bringing that evidence base to bear to the consultation and to the decision-making process that's a shared approach between two experts. The expert is a clinician who will have an understanding of what the options are, what the risks, benefits, and consequences are of the options, but the patient, whose expertise fundamentally lies in their understanding of what's important to them. What's important to them in making a decision, what's important to them in the sort of outcomes they're looking at, what's important to them in their life in relation to whatever decision they're making. And we can think about decision-making as being on a spectrum at one end, paternalistic, doctor, clinician knows best, patient does as told. We're moving away from that model, but there's still a fair bit of it around. The other end of the spectrum, informed choice, is the end where the clinician is a technician, a communicator of information alone. That's conveyed to the patient, and the patient makes the decision on their own, on the basis of what the technician, the clinician, has provided for them. And in the middle of that spectrum is shared decision-making, where the clinicians and the patient work together to come to a decision that's right for that particular patient. As Alan's already said, one critical component of a well-informed patient is the knowledge, the appropriate knowledge, the understanding of the risks, the benefits, the consequences of the options that are available to them. That doesn't mean they have to become a urologist. They just need to understand the important key elements that might inform that decision-making. Equally, if not more important, is knowing what's important to them. We sometimes call that values elicitation. So in that dialogue that occurs between patients and clinicians, there's an element of interactional work that's saying, okay, let's understand what's important to you as a patient in terms of making this decision. Because what's important to you as a clinician may be different. Or if you were in the same position as that patient, you may have a different perspective on it. And ultimately, what you're aiming to do is to come to a decision for that patient that's consistent with their values and is well informed. So, oops. Thank you. Here's a patient, not a urology patient. Can we kick that off? I knew I shouldn't have used videos.
I decided to have a full mastectomy because I wanted to give myself the best possible chance. So that was to get rid of all the breast tissue, which meant that if there wasn't any breast tissue there, there wasn't much of a chance that anything could grow back. And possibly also avoid radiotherapy by having the full mastectomy. And I did actually avoid radiotherapy, so that was good. And I did have those 10 days or so to think about it, and not once during that time did I waver from that decision. If I was going to be deformed, then it was a case of, well, let's be properly deformed, not do half a job. And I did think to myself that it would be so much easier to fit a prosthesis onto the flat chest wall as opposed to trying to fiddle around with bits and pieces, trying to get around half a boob type of thing. So that was, you know, another consideration.
Okay, an interesting way of putting it, but I think it illustrates very clearly somebody who's thought through the issues for them and come to a decision that's consistent with what's important to them. We often refer to these as preference-sensitive decisions, and there's a tendency to think of these as the sort of episodic decision, a choice between breast-conserving surgery or mastectomy, or a choice between watchful waiting or surgery for benign prostatic hyperplasia. But actually, pretty well any decision that patients are making has an element of this shared process to it. So patients who are deciding whether or not each day to take statins or to exercise to reduce their cardiovascular risk, who are deciding whether to continue smoking or not, are also part of this same process. So I think we can think of shared decision-making as much wider than just episodic decisions. And that's just worth keeping in mind. Why do we do it? Well, there's a strong and growing evidence base. A Cochrane review of patient decision aids, and I'll come back to that in a moment, but these are tools that help patients to assimilate the information and understand what's important to them as part of the process of decision making. The latest version, which we've just submitted, has 119 trials, randomized controlled trials. Patients have improved knowledge. They've got more accurate perceptions of the risks. They feel better informed. They're clearer about what's important to them. Fewer of them are more undecided. They perceive more active involvement, and they achieve decisions that are informed and consistent with their values. And it seems as if where there are choices between more and less invasive interventions, on the whole, patients tend to choose less invasive interventions. There's also a growing evidence base that engaging patients in decisions about their treatment improves adherence to that treatment. 50% of the medication we prescribe in the NHS is not used. How much of that is because patients weren't involved in understanding why that medication was valuable, or indeed were being given a decision by a clinician that actually wasn't one they wanted anyway, so they just didn't take it in the first place. And in long-term care, increasingly we're seeing benefits of engagement in terms of outcomes in diabetes, chronic obstructive pulmonary disease, etc. Are we doing it? Not very well. So over the last 10 years, if you ask patients after they leave hospital, were you involved as much as you wanted to be in decisions about your treatment and care, about 50% say they weren't. So we're not achieving that, and it hasn't changed over that long period, despite a lot of discussion around these. So there are certainly things we can do better. Similar question here between 2007 and 2012. Were you involved in decisions about your discharge from hospital? Again, only about half say they were involved as much as they wanted to be. And if you ask doctors, this was a survey done by doctors.net.uk, what proportion of your patients do you believe actually want more information? 65% of doctors said only a minority, so there's a disconnect as well between what clinicians think patients want and what patients are saying they would like. Okay, so what is needed for a well-informed patient? One element of that is evidence-based decision support. How can we make the sort of information that Alan was talking about to inform his decision about his treatment, or the patients you're seeing with prostate cancer need, at the right time and in the right way, not only to the patient, but also to the clinician. We'll come back to it, but one of the things we've been working on is decision aids that can be used within the consultation, which actually help the clinician as much as they help the patient in terms of communicating risks, benefits and consequences, particularly in primary care, where you can't possibly keep all of the evidence or all of the things that you see in practice in your head. there are issues about whether this sort of decision support is best within or outside the consultation. Many of the decision tools that have been developed over many years have been quite complex tools, booklets, DVDs, internet-based tools, which can't be used within a consultation. But again, from some of the work we've been doing and others internationally, there's a sense that there are brief versions that can be of value in a consultation. And then there's the issue about how you fit this to clinical pathways. And we found in some of the work locally that sometimes it's about making the decision fit the pathway, and sometimes it's about making the pathway fit the decision. And that is something that needs thinking through. So brief decision aids are things that can be used within the consultation. Here's an example: heavy menstrual bleeding. I know you don't see a lot of this yourselves. But there are a number of options open to women with this, and a brief decision aid lists those options. What are they? And then very simply and very concisely presents what are the benefits or the risks or consequences of the alternative options. That's an extract which talks about watchful waiting, no active treatment versus intrauterine devices. And it's very easy to present that sort of information in a very concise way. The GP who's talking this through has got the data in front of them. They don't have to have it in their head. And actually it can be used in a way to change the dynamics of the consultation. Clinicians then sit with the patient and go through it, and it's remarkable how that can actually change the actual interaction that happens. Here's another example, an option grid. These were developed in Cardiff, the brief decision aids in Newcastle. Very similar sort of concept. Asks some of the critical questions. Breast cancer here, what are the chances of cancer coming back, and how does that compare if I choose mastectomy or breast conserving surgery? And this makes a difference. These are some data from some work in Cardiff. On the left, this is before that option grid was used in clinical practice, and what those are measures of knowledge. You don't need to worry about the detail, except that the green bar is how well the patients understood those key knowledge items. And as you can see, prior to use of the option grid, that was very mixed. After the option grid, that improved considerably. Similarly, when you go through this process with the patient, and it's not just about the grid, it's also about the discussion, we can see that from the post-diagnostic consultation, there's a lot of uncertainty. What sort of option am I going to take between mastectomy or breast conserving surgery? After a good shared decision-making process, that polarizes. People become much clearer about which of the options they prefer on the basis that they're now better informed and they understand what's important to them. This is just a screenshot from the NHS decision aids. There's one on lower urinary tract symptoms. There's a whole series of these. These are the more complex ones, which you can refer patients to, which are of value in between consultations. And of course, one of the issues here is that patients don't make decisions at a single point in time. Often it's about, particularly if you've got a diagnosis like cancer, that's not the time to be making a decision about alternative treatments. That's a time to come to terms with, what are you telling me, and I need to go away and think about this. So these in between consultation or more in detail decision aids have a role to play there. Okay, can we get that one working, please? A lot of this is not about tools, though.
Well, as I say, communication is one of the main things that you've got today. But if you don't know what's wrong with you, and the doctors don't know what's wrong with you, and the professors don't know what's wrong with you, and this one doesn't know what's wrong with you, it can be very hard to communicate, because the simple thing is, doctors are not too bad, but surgeons and professors and all of the rest of it, and the hospitals and all that, they've got a language all of their own, and they forget. They went to school for about 6 years to learn all these fancy words, but we don't know what they are. So communicating with somebody like a professional, like a professor or a doctor or whatever, they know the medical names for them. We don't. So you've actually got to say to them, excuse me, going to say that in plain English, because you'd need to have one of the medical dictionaries and you'd be there all week trying to figure out what the one word was that he said. So you've actually got to say to them, look, I don't understand what you're saying. He might understand what he's saying, but you don't. So you've got to say to him, look, you have to explain it to me in my language, not yours. And that can be quite, because an awful lot of surgeons and professors can be quite, look down their noses at you kind of a thing. You're supposed to do as I tell you. Like it used to be years ago, you didn't answer the doctor back, and you didn't do this, and you didn't do that. I mean, you done your tell. Whereas now you seem to be more open. You can actually say to them, no, I don't agree with you, without being a very bad person, do you know what I mean? Whereas years ago, you don't answer the doctor back, whatever he says, ring me, that's it. No, you've got to live with it. But you don't know. It's a case of, you have to ask them to tell you what's wrong with you in your language, no theirs.
So wonderfully insightful, although an interesting concept of plain English, I think. The point here, though, is we've talked about tools and decision aids, but fundamentally what underpins this is clinical skills. And in the work we've been doing in implementation, this is the cornerstone of getting this right. It's about attitudes and awareness, which are absolutely critical, and it's about developing a set of skills that actually in most of our curriculum training, whether it's undergraduate, postgraduate or continuing professional development, we don't do at the moment. This is about the second half of the consultation. It's that part of the consultation when you've done the diagnosis, you've talked about what the issues are and what the problem is, and you're coming around to this really more difficult bit about decision making. And what we found in the training we've been doing is that that's really eye-opening. If you can get clinicians involved in role-play-based training, there's a clear move from we do this already to I think we do this, but we could do it an awful lot better. And one of the key issues of learning here is not so much about the risk communication and that there are options and choices, but it's that bit about understanding what's important to the individual patient in front of you. That's one of the big tasks and one of the big challenges in this setting. We've used a particular model of the consultation to help us teach this. It's a model, it's a conceptual model. Consultations don't work in this linear role, but it's a way of thinking about this. There's choice talk, i.e. making it clear that there are some choices here. Just introducing that idea, because often patients expect to be told that there's one thing to do. Option talk, which is then what are the choices and what are the risks, benefits and consequences of those. And what you're seeking to do in this interaction is all your patients will come with some sort of prior preference, some sort of prior knowledge. It'll vary dramatically between them. Some of them will know what some of those options are, some will have no idea, some will have gone to the internet and got something completely out on a limb. But you're wanting to move them from those prior preferences to informed preferences and then to make a decision that's informed and consistent with their values. And as I say, decision support tools have a role here, but you're never going to have enough decision support tools for every clinical decision. So the skills in the consultation are absolutely critical here. Another issue here very quickly is, this is not a term I like, patient activation, but it tends to be one that people are using. How can we get patients to engage with this? Because it's not just about changing clinicians' expectations and roles in the consultation. Much of this is about past expectations of our patients who've grown up in a service that doesn't necessarily invite them into this decision-making space. One way is question prompts. Again, we found in the work we've been doing that 3 simple questions can be really helpful here. What are my options? What are the possible benefits and risks? And how can we make a decision together that's right for me? We don't suggest patients go in and ask those questions, but we suggest patients have those in the back of their head during their consultation. And we've used that by putting these out as flyers in waiting rooms, by sending them out with appointments letters, by producing a short film that enables them to think this through. Some of the decision aids use patient stories very effectively. Patient stories are very powerful, but it's important that the patient story is tailored to the decision. This is a screenshot from a North American decision aid, but it basically makes it clear through patients' own words how they made decisions about whether to have prostate surgery or not, based on the way they balanced the severity of their symptoms with concerns about sexual dysfunction post-surgery. One of the concerns, I suppose, is that if we get activated patients, what we get is a whole load of people coming in with streams of inappropriate information, and you spend all your time trying to put them right. I think there are ways around that. And anyway, this is the world we live in, quite rightly, so get used to it in a way. One interesting way around that, and you'll hear more about it in the next talk in terms of helping patients to navigate through this process, is an example here actually in chronic care from diabetes. If you go to see your financial advisor, you don't expect to turn up and see them and they will tell you what your latest bank balance is and so on and so forth. You'll have that information in advance of seeing them. And yet we expect patients to go to consultations and be told, oh, here's your results from the blood test last time. And that's new to them. In chronic diseases and diabetes, one really powerful thing that's been implemented quite widely now is the idea that patients get their results with some interpretation before they go to their review clinic. That makes for a much more robust, a much more mature, a much more thought through and prepared consultation. Okay, quick summary. Shared decision making is much more than tools. They have their value, but it's much more to do with skills and new ways of consulting. Complex decision aids have a role, but simpler in-consultation support tools have their role too. We need to think about how to embed this in pathways or adapt, and there's an important emerging role of patient activation. Thank you. I'll hand over to the next speaker.